Tests for the thumb and fingers. Skier's thumb test. The physician should check if the ulnar collateral ligament of the thumb is torn. The thumb should be fully extended. The physician stabilizes the metacarpal with one hand while using the other hand to push the metacarpophalangeal joint into radial deviation. A complete ulnar collateral ligament tear will normally allow at least 15 degrees radial deviation compared to the other normal thumb. Thumb adduction test. The patient is asked to raise his thumb while the physician applies downward resistance. Weakness is a positive sign. Weakness in the thumb abduction and decreased sensation doubles the likelihood of carpal tunnel disease. Thumb movement or Finkelstein's test or the triple flexion test. To test the thumb function, the physician asks the patient to grasp the thumb against the palm and move the wrist toward the midline in ulnar deviation. The interphalangeal joint, the metacarpophalangeal joint, and the fingers are all flexed. Pain during this procedure indicates de Quervain's tenosynovitis due to an inflammation of the abductor pollicis longus and extensor pollicis brevis tendons and tendon sheaths, a diagnosis proven as well by a pain and swallowing at the radial border of the wrist. Fingers. To check the flexors of the fingers, a doctor should think about flexor digitorum superficialis and the flexor digitorum profundus. The superficialis flexes the proximal interphalangeal joint, so by holding the other joints in extension and asking the patient to extend and flex the finger a few times, the physician should know that the tendon is working well. If the physician immobilizes the proximal interphalangeal joint and asks the patient to flex just the fingertip, he would be testing the function of the flexor digitorum profundus. Incapacity to flex the distal phalanx indicates an injury in this muscle. If the physician puts the patient's hand in a supination position, the fingers should be normally fully extended. Functional assessment. Grip strength. The physician asks the patient to grasp onto two of his fingers and to not let them go against resistance. Pincer grasp. The physician asks the patient to hold on a coin or a piece of paper by opposition of the thumb and another finger, and it could be done against resistance. Key grip test. The physician asks the patient to hold a key and rotate it as if he was locking a door. Dexterity test. The patient should be able to write a few random words correctly or press certain buttons in a correct way. Neurological tests. Ulnar nerve test. The physician asks the patient to abduct the fingers and resist his squeezing action. It tests the dorsal interossei muscles of the hand, supplied by the ulnar nerve. The physician can ask the patient to adduct his fingers and resist his spreading action, which assesses the activity of the palmar interossei muscles of the hand, supplied by the ulnar nerve as well. Median nerve. Thumb abduction, flexion, and opposition are supplied by the median nerve, which are weakened or abolished in the case of a carpal tunnel syndrome, depending on its severity. Vascular tests. Allen's test. The physician compresses the ulnar and radial arteries at the level of the wrist and asks the patient to repetitively flex their fingers, then to stop after around 10 seconds. The doctor then stops compressing the ulnar artery only. Normally, the hand should pass from a pale color to a reddish one. The same test is repeated, but this time the compression is inhibited on the radial artery. The hand should normally pass from a pale color to a reddish one. Nail blanch test or capillary nail refill test. The physician applies pressure on the patient's nail until it turns white, then releases the pressure. The nail should go back to its original color in 3 seconds maximum.